Bullous pemphigoid, autoimmune blistering disease in elderly patients. Bullous pemphigoid is a chronic autoimmune condition characterized by fluid-filled blisters that develop between skin layers. This condition predominantly affects older adults and results from antibody attacks on basement membrane proteins. Understanding bullous pemphigoid. Bullous pemphigoid represents a significant dermatological challenge, particularly in the elderly population. This condition belongs to a group of autoimmune disorders that target the skin's structural integrity, resulting in the formation of large, fluid-filled blisters. Unlike some other blistering disorders, bullous pemphigoid develops when the immune system mistakenly produces antibodies against proteins that serve as anchors between different layers of the skin. Understanding this condition is crucial for both patients and healthcare providers, as early recognition and appropriate management can substantially improve outcomes and quality of life. Epidemiology and risk factors. Bullous pemphigoid predominantly affects individuals in their 7th decade of life and beyond, making it primarily a disease of the elderly population. The incidence tends to increase with advancing age, with the majority of cases occurring in people over 60 years old. While this condition can occasionally manifest in younger individuals, these presentations remain relatively uncommon. Several factors may increase susceptibility to developing this disease, including genetic predisposition, certain medications, and the natural decline of immune regulation that accompanies aging. Environmental triggers and underlying systemic conditions may also play roles in disease initiation, though the exact mechanisms remain subjects of ongoing research. Pathophysiology and immune mechanisms. The underlying mechanism of bullous pemphigoid involves a type 2 hypersensitivity reaction, wherein the immune system generates antibodies specifically targeting hemidesmosomal proteins. Hemidesmosomes function as critical adhesion structures that anchor the epidermis, the outermost skin layer, to the dermis below. When antibodies bind to these junction proteins, they initiate a cascade of immune responses that progressively weaken the connection between skin layers. This disruption leads to the accumulation of fluid in the space between the epidermis and dermis, ultimately resulting in blister formation. The primary antigens involved in this autoimmune response are BP180 and BP230, both integral components of hemidesmosomes that maintain skin structural integrity. Clinical presentation and symptoms. Patients with bullous pemphigoid typically present with characteristic symptoms that warrant dermatological evaluation. The condition is notable for its marked pruritus, with intense itching frequently preceding the appearance of visible skin changes. This itching sensation can be severe enough to disrupt sleep and significantly impact quality of life. The blisters themselves are typically large, tense, and filled with clear fluid, distinguishing them from the flaccid blisters seen in some other autoimmune blistering conditions. These lesions commonly develop on areas subject to friction or pressure, such as the flexural surfaces of the arms, the inner thighs, and the lower abdomen. The oral mucosa may occasionally be affected, though this occurs less frequently than in related conditions. Key points: large, fluid-filled blisters that do not rupture easily. Intense pruritus that often precedes blister formation. Urticarial or eczematous patches appearing before blistering. Preference for lower abdomen, inner thighs, and flexural areas. Diagnostic approach. Accurate diagnosis of bullous pemphigoid requires a combination of clinical assessment and laboratory investigations. Dermatologists typically begin with a thorough history and physical examination, followed by confirmatory tests to establish the diagnosis definitively. Skin biopsy with histopathological examination remains the gold standard for confirming bullous pemphigoid, revealing subepidermal blistering with preserved basement membrane and characteristic inflammatory infiltration. Direct immunofluorescence testing demonstrates linear IgG and C3 deposition along the basement membrane zone, a finding that clearly distinguishes this condition from others in the differential diagnosis. Indirect immunofluorescence or serological testing can identify circulating anti-BP180 and anti-BP230 antibodies, providing additional diagnostic confirmation and potentially offering prognostic information regarding disease severity. Differential diagnosis considerations. Several conditions must be distinguished from bullous pemphigoid when evaluating patients with blistering disorders. Pemphigus vulgaris, another autoimmune blistering disease, produces intraepidermal blistering rather than subepidermal involvement and exhibits different immunofluorescence patterns. Dermatitis herpetiformis presents with smaller, intensely pruritic vesicles and is associated with celiac disease, distinguishing it clinically and serologically from bullous pemphigoid. Linear IgA disease represents another important differential consideration, though it typically occurs in a younger population and has different antibody targets. Porphyria cutanea tarda causes photosensitive blistering with fragile skin, particularly on sun-exposed surfaces, and produces characteristic urine findings. Careful clinical correlation combined with appropriate diagnostic testing allows clinicians to differentiate these conditions and initiate appropriate management strategies. Treatment strategies and management. Management of bullous pemphigoid requires a stepwise approach tailored to individual patient characteristics and disease severity. Topical corticosteroids represent the first-line treatment for mild to moderate cases, effectively controlling inflammation and suppressing blister formation in many patients. Potent topical agents applied directly to affected areas can achieve therapeutic benefit while minimizing systemic exposure. For more extensive disease or inadequate response to topical therapy, systemic corticosteroids become necessary, with oral prednisone or prednisolone being commonly utilized. Steroid-sparing agents gain importance in patients requiring long-term management to minimize the adverse effects associated with prolonged systemic corticosteroid use. These adjunctive therapies work through various mechanisms to enhance disease control and allow gradual reduction of corticosteroid doses. Key points: topical corticosteroids for mild to moderate disease. Systemic corticosteroids for extensive involvement. Steroid-sparing agents including azathioprine and mycophenolate. Biologic therapies targeting specific immune pathways. Prognosis and long-term outcomes. The prognosis for bullous pemphigoid varies considerably among affected individuals, though many patients achieve good disease control with appropriate treatment. Some patients experience remission with complete resolution of symptoms, while others require ongoing management to maintain disease stability. The chronic nature of the condition means that treatment may be necessary over extended periods, with periodic flares requiring therapeutic adjustments. Mortality associated with bullous pemphigoid itself is uncommon in the modern era, though complications such as secondary infections, nutritional deficiencies, or medication side effects can impact overall health outcomes. Earlier diagnosis and initiation of treatment generally correlate with better clinical outcomes and improved quality of life. Patient adherence to treatment regimens and regular monitoring by dermatologists contribute significantly to achieving favorable long-term results. Patient education and self-management. Empowering patients with knowledge about their condition facilitates better disease management and improved outcomes. Understanding the chronic nature of bullous pemphigoid helps patients develop realistic expectations and maintain medication adherence even during periods of clinical improvement. Skin care practices play an important role in preventing complications, including avoiding trauma to affected areas, maintaining cleanliness to prevent infection, and using gentle washing techniques. Patients should be counseled about recognizing early signs of disease flares and the importance of prompt treatment initiation when symptoms worsen. Discussion of medication side effects and monitoring requirements helps patients understand the necessity of regular follow-up appointments and laboratory tests. Support groups and reliable patient educational resources provide valuable psychological support and practical information for managing this chronic condition. Current research and future directions. Ongoing research continues to expand our understanding of bullous pemphigoid pathogenesis and to identify more effective treatment approaches. Investigations into the specific mechanisms underlying immune tolerance breakdown may eventually lead to preventive strategies. Advances in biologic therapies and targeted immunotherapies show promise for patients who are resistant to conventional treatments or intolerant of their side effects. Studies examining the role of various environmental triggers and genetic factors may help identify high-risk populations. Novel biomarkers are being developed to predict disease course and treatment response, potentially allowing for more personalized therapeutic approaches. Collaborative research efforts between dermatologists, immunologists, and molecular biologists continue to advance the field and improve outcomes for bullous pemphigoid patients. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.